knows an awful lot more about medicines than I do, so we'll hand you over to her. She'll please feel free to ask her any difficult questions, and that's absolutely fine. Anyone needs to stand up, move around, feel free. If you need any withdrawal chair,
Whilst that sets up a minute, as Adam says, my name's Ali, I'm one of the rheumatology specialist nurses. Definitely a couple of faces that I recognise in here, being on biologics. The only time you'll actually meet me is if you get a call to in that therapy. Because it's my job to make sure that you fulfil the criteria and that you know enough about it to make a decision about whether you want to go ahead with it or not, because we're not involved with it. So, arms, you don't want to fit. My little doctor don't want to fit. Sit on the other side. So literally what I'm going to do today is spend about 10 minutes just whipping through some of the medications. A lot of them Dr. Boom has already been through. So some of them you'll find a little bit repetitive. I do apologise for that. But so, most people with AS do respond really, really well to a combination of the anti-inflammatory medications, which we also call NSAIDs, exercises for AS topped up with painkillers. But some people also get a little bit different disease, or slightly more severe disease, in which case we need to start adding in different medications on top of that. So in slightly more severe AS, or if you get problems with your what we call your peripheral joints, so your shoulders, your elbows, your wrists, your hands and your knees, we may need to add in more medications to that. Some patients do experience mainly the back, neck and hip pain, and some do get a lot more involved than that as well. There can be a whole variety of symptoms related to AS. So your NSAIDs, these are your anti-inflammatory medications. They can help to reduce the inflammation as well as pain, but they're not actually a painkiller. You can take a painkiller on top of it. Most people with AS will actually be taking some kind of anti-inflammatory medication, because it's the main medication that we use to control your AS symptoms. So examples, as Dr. Boom was talking about a few earlier on, include naproxen, ibuprofen, diclofenac, atopiroxine, but there are more than that. These should be taken either with or should be after food, because they can have negative effects on your stomach as well. Sometimes, if you do experience a few side effects with it, you may end up with another medication on top of that yet again, just to help protect the lining of your stomach, something like omeprazole or lansoprazole, for example. NSAIDs, different NSAIDs are taken in slightly different ways. There are some slow release or modified release preparations that you take once a day and it will last you until the next day. Other ones need to be taken on a much more regular basis. So make sure you get some counselling from either your GP or you consult whoever prescribes those for you as to how often you should be taking them. They do usually work very quickly, but can sometimes take a couple of weeks to get to full benefit. So we do recommend that at least when you're either first diagnosed or even if you're you take them on a regular basis to start with. Some of the side effects I've already touched on can include stomach pain, indigestion and headaches. So if you do get any side effects at all, either speak to your GP or speak to one of us about it. Painkillers, also known as analgesics, there's loads of them and I haven't tested all of them because we'll be here forever and a day talking about them. They're there to reduce the pain. They're not there to reduce inflammation, that's what your anti-inflammatories are for. These are literally to help block the pain pathway so that you are more comfortable, you can function on a day-to-day basis a lot better, and you can do your exercises for your AS a little bit better as well. It's really important to control the pain because it helps to keep you moving. Okay? Examples of painkillers, as Dr. Quinn touched on a few earlier on as well. Paracetamol sounds really simple but really, really effective painkiller. Cocaine, my voice is going to go now. Tramadol, but there are loads of others. We start off with simple analgesics. If you either your body gets used to them and you need something a little bit more, or it doesn't quite control the pain, we'll gradually move on through the different groups of painkillers. Steroids, again, as Dr. King very briefly touched on, can be really effective, particularly if you're first diagnosed or if you're in a flare of your AS. They're used to literally dampen down the effects of the inflammation on your body. They don't do anything to control the inflammation. It's like throwing a fire blanket on top of the fire. It helps to put the flames out for that period of time. They can be used either as a tablet in the form of oral prednisolone, which are really good if they give you a short course of oral steroids. Sometimes we'll just give you 10 days, 2 weeks, starting at a high dose and whittling down fairly quickly. They can also be given as an injection, a depinephrine injection, which goes into your bum. That can be really useful if you have widespread pain and it's not in just one area. They can also be given, as Dr. Quinn touched on earlier on, either as a drip straight into your vein if these ones don't work, or they can be given directly into the area that's causing inflammation and outcomes. Okay? Again, they are particularly useful during flares. So disease-modifying anti-rheumatic drugs. These are generally given to people who have what we call peripheral arthritis. So arthritis affecting your joints other than your back, your neck and your hips. Okay? Usually it's an inflammatory type arthritis which can be associated with your AS. Drugs that we would use usually are methotrexate and sulfasalazine. We don't tend to use them in patients who only have back, neck and hip symptoms because they're simply not proven to work in those patients. We will only use them if you have the peripheral joint involvement as well. And as Dr. King touched on earlier on, you need blood monitoring with it because they can cause adverse effects with your blood test result. And you do need to be seen quite regularly whilst you're on them. It can take up to 12 weeks really to become effective as well. Okay. Sometimes patients with AS can also get nerve pain. It can happen sometimes if there's an area of damage in your spine which is pressing on the nerve. We term that as neuropathic pain. Type of pain can be helped by medications that actually we normally use to treat other conditions such as epilepsy or even depression. But they work really, really well in this type of nerve pain. Examples of this are amitriptyline, gabapentin and pregabalin. Does anybody know anybody who's on those types of things? Yeah. Find it useful? Yeah. Not necessarily. It also depends on what kind of, whether it is just nerve pain or whether you are also having problems and struggling to get to sleep at night as well. Right. Yeah. But I found amitriptyline with side effects of to get the woozy hangover feeling the next day. Yeah. One of the main side effects of people not being able to tolerate.
Less of the woozy, isn't it?
Yes, it does. And it is much better for purely neuropathic pains as well. Quite often used by chronic pains as well. If you are struggling to get off to sleep at night, quite often we'll prescribe you a fairly low dose of amitriptyline to start with, because starting at 10 milligrams and then going up as we need to. A lot of people don't tolerate it brilliantly because it can leave you feeling a bit muzzy-headed, hungover kind of feeling the next day and struggling to function very early in the morning if you have to get up early. We normally recommend that you take it a couple of hours before you actually wanted to go to sleep. So if your bedtime's at 10 o'clock, you take it at 8 o'clock. Generally, if you do get the side effects, we ask you to bring it back another hour and keep bringing it back a little bit if possible to try and reduce that. It's much more common to get the side effects within the first couple of weeks of taking amitriptyline. And in some cases, it will settle down the longer that you're on it, but some people just don't get on with it particularly well. It's like with any medication, some people do well with it and some people don't. Then you've got the biological medications, the anti-TNF medications, which I'm not going to go into a huge amount of detail because Dr. Quinn has just done, Dr. have gone into a lot of detail about that. But they are the newer medications, and they are reserved for patients with severe ankylosing spondylitis who haven't responded to standard medications. What we mean by standard medications essentially is anti-inflammatories alongside the exercise programme. You have to have tried and failed at least 2 anti-inflammatories, and you have to have a high enough bastard score and kind of Spain score to be actually able to go ahead with it. Okay? That's when you would see Adam and I together in combined clinic that we do for patients who are either being assessed for or who are on TNF medications. Okay? As Dr. Puma said, the 3 main examples of anti-TNF that we have available at the moment are adalimumab, etanercept, and ipilimumab. Hopefully, we'll see some new ones coming up though. That would be nice. Okay. That's about all I've got for you on medications, unless there are any questions.
Yes, I've got a question on drug interaction.
Yeah.
I'm on 20 milligrams of methotrexate for uveitis, taking naproxen when I'm needed for AS, but I'm told that I shouldn't take more than 250 milligrams of naproxen when I'm having methotrexate. What can I top the naproxen up with when that's not sufficient for the pain, which will not interact with the methotrexate?
There is a theoretical interaction between methotrexate and anti-inflammatory medications. Usually they're at very high dose and with sustained use. But in our practice, we quite often use them both together. In patients with rheumatoid arthritis, for example, we'll quite often use 25 milligrams a week of methotrexate alongside anti-inflammatories and painkillers, and we see very, very few interactions between the two.
So what sort of painkillers? I find paracetamol doesn't really have much effect on AS.
There are lots of other painkillers that you can try. Have you tried something called cocodamol? It's a combination
in
of
the
paracetamol,
past, yes,
codeine.
yeah.
That can be quite useful. As can tramadol can also be quite
Tramadol's
useful.
quite strong.
It is, but you can, the combination of tramadol with paracetamol can actually be really quite effective as well.
So probably cocodamol, and so that and say 250 milligrams of naproxen would be okay with 20 milligrams of methotrexate.
Absolutely. You'll find in community pharmacies you'll be advised against taking methotrexate alongside an anti-inflammatory. But as I say, we do it in hundreds of patients with very few problems.
I was told at our hospital, as long as I don't exceed 250 milligrams of naproxen, then that should be okay with methotrexate. So cocodamol looks to be the third part
Cocodamol
when I
would be
need
the next
it.
step from paracetamol if paracetamol is not quite cutting it.
And will I need to get that on prescription, or can I get that over the counter?
No, you can get the lower dose of cocodamol over the counter, the 500 milligrams of paracetamol mixed with 10 milligrams of codeine. But I also want to talk to your GP about extra painkillers so that they're aware of your situation too.
And if I needed that, what dosage should I start out of the cocodamol?
Cocodamol you take on a very regular basis. What I call regular is 2 tablets every 4 to 6 hours, but not exceeding 18 to 24 hours.
Okay, thank you very much.
All right. Yeah, the only downside to codeine is it can burn you up.
If you go on to anti-TNF, do you have to have steroids with it?
Not necessarily, no. The only treatment with anti-TNF is to control the inflammation in your blood. If you control the inflammation in your blood, theoretically it shouldn't be able to attack the joints. So in theory, you should be able to get away with nothing but anti-TNF therapy.
So if that brings you down with inflammation, why do people get pneumonia?
Why?
Yeah.
Some people are just
Prone to it?
not necessarily. I mean, some people do get.
But it's not over to its hand.
Not necessarily. I mean, some people are prone to certain infections. You'll find that there are groups of people who, if they get an infection, it goes straight into their chest. You get other people who get throat infections quite regularly.
It's not particularly.
It's not necessarily the anti-TNF that is causing it, but it does put you at a slightly higher risk of any opportunistic infection, such as colds, chest infections, flus, anything that you'll find in the
is hepatitis C that down, any hepatitis?
We screen for hepatitis B and hepatitis C before we proceed with anti-TNF because we know from research that we need to be a little bit more careful with patients in those groups. Okay.
Is there any problem of working with cattle with TB?
Working with cattle with TB? Yeah. Not necessarily. We do have some patients who work in a lot of different areas. It wouldn't necessarily stop us from doing ICU, but we would want to screen you for TB first.
And is there any problem taking any of this if you're on blood pressure medication?
No, not at all.
Not the NS? No, because I was told not to take them because I'm on high blood pressure.
No. You should be a little bit careful with anti-inflammatories if you have known stomach problems, kidney problems, or really bad asthma, because it comes up with any one of those after all that. But usually with blood pressure medications, it's fine. Okay.
Right, with non-anti-inflammatory steroid drugs, can you take it with if you've got IBD? Because I've had conflicting information.
You can, but you need to be a little bit careful because it can upset your stomach.
Right, okay.
There are some patients with IBD who are absolutely fine and take anti-inflammatories, but there's also probably the same amount of people who can't take it because it's just too rough on their heads.
Right, okay. I think that'll be right, okay.
The anti-inflammatories,
Yeah.
obviously you say you've got problems with your kidneys, you've got some infection, you've got an infection for the whole 5 years. Every time I take anti-inflammatories regularly, I take anything that's a kidney infection, and so that stops me taking them all the time.
Yeah.
So my kidneys are technically was working, so that's the reason why I was in hospital. I think I've tried them all. and I've been on them, and it was just even worse.
Yeah, yeah. It's difficult to judge on a case-by-case without knowing you and your personal history. But, you know, the reason that we say be careful in patients with kidney problems is long-term use of an anti-inflammatory can cause reduced renal function and can be a little bit careful.
I get really bad. My son's really sensitive. I'm on like all that you can think of. What would you recommend the best anti-inflammatory for me to go for? Like to take regularly. I just find I've tried all of them and it's just made that I end up with so much stomach problems. What's the easiest one to kind of take that will actually have an effect? So that's what I just find. I can't take really strong ones because I just end up in so much pain with my stomach.
It's difficult to say. In cases like yours, sometimes it just comes down to trial and error.
Really?
Just got to keep on trying different ones and seeing what kind of effect it has, and if you can't tolerate it, try something else. Lots of them out there to be tried, but there's not necessarily one that is proven to be any better than the others.
Do you reckon you're being a blood test with some urine? Because I've just realised how it doesn't have a blood test. It's using on the proxy for
It wasn't.
he was only having full blood count and he wasn't having blood cells. So should perhaps have this renal test done?
Start using these done perhaps once every year or so just to make sure it's okay. But unless we actually knew what the renal function was like before we went on to anti-inflammatories, we wouldn't necessarily know there's been a change.
What's the difference between these three fantastic names?
The great big long names.
Yeah, the shorter names are easier. But is there a fundamental difference?
There's not a massive amount of difference. They're all anti-TNF medications. They will all potentially do the same job. They will all target the TNF protein and try and knock it out of action to try and disrupt the balance in the way that the inflammation is produced. The main differences between them is the doses and how often they're given. Sometimes we might turn around and say, actually, if you have inflammatory eye disease as well as back, neck and hip pain, as well as a whole host of other problems, we may actually turn around and say to you that the adalimumab would be better because it does cover so much more of your symptoms. But if you have classic back, neck and hip pain, any one of them is likely to do the job we want it to in the first instance. So of interest, the adalimumab is given once every 2 weeks, the etanercept once a week, and adalimumab is once a month on the same date of every month. Yes, the also. Any other questions?
Is there anything particularly recommended if you do get a lot of iritis?
The eye hospital usually manage that, to be fair.
So you don't know if any of these drugs are particularly good at...
Adalimumab is sometimes used as well as another medication which isn't licensed for ankylosing spondylitis, so I haven't put it on there. But there is another one called infliximab, which the eye hospital sometimes use for inflammatory eye problems.
Just as an experience, I mean, I used to have iritis quite a lot, but after starting being around, special last 5 years.
They're not better.
But not in the last 5 years.
No.
Any more questions? Can we move this on?
Just wanted to know, if you've tried the two anti-inflammatories,
Yeah.
why would you go straight onto the anti-TNF and not the methotrexate?
It depends on what your symptoms are, okay? If you have purely back, neck and hip pain, we wouldn't use methotrexate because it's not proven to work in those cases.
Right.
We'll only actually use it if you have an associated peripheral arthritis that affects your other joints as well.
Okay.
I don't know, it does seem like quite a big jump, doesn't it? Anti-inflammatories, anti-TNF.
Yeah. I just wondered why the one in between. Yeah, but
Yeah.
I remember you said that earlier. Yeah.
Okay.
Lovely. Any more questions? Fantastic.